Hello, guys. Good evening, everyone. And many thanks for joining us in this educational evening. This session today is organized by the Orthopedic Academy, and our guest of honor is Mr. Akil Kapoor. Mr. Kapoor is a consultant orthopedic surgeon who works in Essex in Queen's Hospital. He's specialist in both upper limb and lower limb, and that makes him perfect guest lecturer today to give us this talk. We are recording this, and this will be part of our Principles of Orthopedic course, which you can find full details about in the Orthopedic Academy website. I might share a link later on in the chat. Everyone who attends will get a certificate of attendance as well today. With me today as well is Nikki Evans, who is a senior faculty member of the Orthopedic Academy, and herself, Akil, and myself, three of us will be here for you to answer any queries you might have or questions. So the session will start with a lecture, which will focus on the principles of orthopedic oncology, both for diagnosis as well as management. We will then have 3 MCQs. The answers will be anonymized, so we encourage you all to try to answer these. So please stay focused during the lecture so you can answer the questions correctly. Following the MCQs, we will have some case discussions. And if any one of you would like to take part in the case discussions, please let us know. Just raise your hand symbol or just send us a message in the chat box. So thank you for everyone, and I will leave you now with Mr. Kapoor. Over to you, Akil.
Thank you, Firas, for the lovely introduction. Welcome all delegates and participants. Today's topic of discussion is Principles of Orthopedic Oncology. I'm Mr. Kapoor. Today's talk, as an overview, we're going to be talking about the burden of bone tumor, the epidemiology. We'll discuss a bit about etiopathogenesis. We'll also broadly discuss what are the common and the not so common types of bone tumors that we encounter in our clinical practice. We're going to discuss how and see how patients present and what are the diagnostic tools available to us and modalities available for us to correctly diagnose them in a timely fashion. Particularly important is for you to understand a multidisciplinary management approach towards managing these patients, as it is quite a complex part of orthopedic practice. We will then see some clinical treatment strategies and management options. And as mentioned before, at the end, we'll do a few MCQs and discussions. So coming to the epidemiology and the burden of the tumor. Bone tumors can be divided mainly into primary bone cancer or secondary bone cancers. So primary bone cancers arises from mainly the connective tissue, which could be bone, cartilage, muscle, or fat. One of the most common portions or parts of the body which can be affected is the lower limbs, especially the lower end of the femur or the upper end of the tibia, because they are quite vascular areas. For some figures, in 2017 in UK, there were total cancer cases, out of total cancer cases of 363,000 roughly, bone cancer primarily formed 0.155% of these group of patients. The very common age groups for bone cancers are bimodal. There is a bimodal pattern of diagnosis where there is a group between adolescents and young adults, and then it peaks beyond the age of 50 years of age. It is slightly more preponderant in males than females. And then comes the other group of bone tumors, which is secondary bone cancer. For example, a metastasis from a primary, like a lung, prostate, breast, kidney, and some other areas. But these are the four more common, where the primary is metastasizing to the bones. There are, regarding the etiopathogenesis of bone cancer, there are some risk factors which can make a patient more vulnerable to getting a bone cancer. More commonly, it is sporadic in nature. However, it can be associated with some inherited conditions, some genetic mutations, translocations of genes, or presence of tumor suppression genes, suppressor genes. Some patients who've had some kind of cancer treatment, like radiation, chemotherapy, or drugs, may also be more susceptible to developing bone tumors. There are certain syndromes and conditions like Lifromany syndrome or retinoblastoma, which can also have high preponderance of bone tumors. And one particular condition called the Paget's disease of the bone also has high risk of bone tumors. If we look at this slide, I've divided it into two age groups as we discussed. It could be on the left, we see the adolescent and young adult age group. And on the right, we see the slightly more adult, beyond the third decade or fourth decade. If you see, this is the lower end of the femur, and this picture is basically giving you a rough idea of what kind of tumors that we come across in clinical practice. So if we focus our attention to the slightly younger adult group on the left side, we have, from the top, we have things like fibrous dysplasia, which is in the middle of the shaft of a bone in the diaphysis area. Then we see Ewing's carcinoma, which is a slightly more, which is quite an aggressive tumor, which is also in the shaft of the long bone. As we come towards the metaphysis of the bone, which is the junction between the shaft and the growth plate, which is called the physis, we see several tumors. Most of them, if you see, like the non-ossifying fibroma, simple bone cyst, osteoid osteoma, osteochondroma, or also known as exostosis, aneurysmal bone cyst, ABC. Most of these tumors in this picture are benign tumors. Now, for those who have not heard that term, benign is a less aggressive category of tumors, and the ones which are more aggressive are called sarcomas or malignant tumors. So in the metaphysis, all this group that we just mentioned are all benign tumors. Exception was this Ewing's sarcoma, which is an aggressive sarcoma, and the osteosarcoma, which happens to be at the junction of the metaphysis and the epiphysis, is also an aggressive tumor. So looking at the epiphysis itself, chondroblastoma can be a lesion which is benign again. Now, if we focus our attention on the right picture, this is showing a metastasis in the center of the diaphysis and close to the metaphysis. And this is a secondary sarcoma, as we discussed, coming from a primary elsewhere. This is another picture. Now that we have a broad idea about what kind of tumors we see, this is a nice picture which I picked up because it shows the same area of the knee with the lower end of the femur and the upper end of the tibia, but it shows most of the tumors' classical radiological appearances as well as the more common locations of these tumors. So it's kind of a revision, but more focusing on the appearances. So from the top, fibrous dysplasia is a benign lesion in the shaft of the long bone. This is an exostosis, also called an osteochondroma, benign again. This lesion that you see here, which is a moth-eaten appearance of the shaft, is a more aggressive lesion. And we will talk a little bit more about it. But if you focus your attention here, you can see some lines around the periosteum. This is called onion peel appearance, and this is very classical of a very aggressive lesion, which is malignant. These are other benign lesions, chondroblastoma or bone island. Coming down, osteosarcoma is, as the name suggests, wherever there is a name which ends with a suffix sarcoma, it has to be a malignant or aggressive lesion. So just like Ewing sarcoma or osteosarcoma. So osteosarcoma, again, it is in the metaphysis. It leads to a sunburnt appearance of elevation of the periosteum, and it's an aggressive lesion. If you focus your attention on the fibula, it is showing two different lesions. Now, both these lesions look a bit different. Both of them are benign lesions. They are not malignant. So the top one is a well-defined lesion, and it's called a simple bone cyst. However, the one at the bottom, which is this one, has ballooned up, and it is called an aneurysmal bone cyst. Now, both of them are benign. The only difference is that this one is much bigger in size, and this bone is much susceptible to fractures. Now, on that note, if a bone fractures through a cancer lesion, the fracture is called as pathological fracture. So I will let you ponder around and have a look at these lesions, how they are appearing. We will discuss them in a little bit more detail in the next few slides as well. But the main thing to understand is to trying to understand what are the terms which tell you that this is a benign or a less aggressive lesions, and which ones are the more aggressive lesions and malignant lesions. What are their locations, and what are their classical appearances? So this is quite a complex flow chart, but we're not going to go in too much details because I understand we're not going to discuss too much management in details, but what it's trying to show is the division between primary care and hospital or subspecialty care in a higher tertiary center. You as doctors or any specialist or physiotherapist may encounter a patient at any on any platform. It could be a urgent care center, it could be a GP surgery, it could be A&E, or even the physiotherapy department, so or a radiographer. So patients presenting with bone pain and swelling, the first thing after clinical assessment we do is a plain radiograph. So it's very important to be able to assess the radiograph and get a rough idea whether this is a benign lesion or is it a more serious, aggressive, malignant lesion, because that helps us decide which way we're going to go down the route of management or referral. And we'll talk about it again more in detail in the next few slides. So before we go on to the management, we again focus on the X-ray. So what are the things that you see on a plain X-ray that we need to address? And we need to see, to be able to decide whether this is a benign or a malignant lesion. So first is the pattern of destruction. So whether this is a geographic or a very localized lesion, as in the first picture, or the lesion is more extensive and eroding the bone over a very, very long zone in the bone, and that is called moth-eaten, or it is permeative and there are no boundaries and it's just eroding everything and there is no proper corticomedullary differentiation available. So if it is geographic, like on the left, it is less and it's well defined. It's a non-aggressive lesion and more likely to be a benign lesion. However, if the lesion of the pattern of destruction to the bone is more permeative, it becomes more aggressive. Second thing we need to see is what is the margin, what is the zone of transition of the borders of this lesion? Can you very clearly define the zone of transition? Okay, so from a lytic lesion, the normal bone suddenly appears. That means there is a narrow zone of transition. That means a well-defined lesion and it's likely to be benign. However, on the right picture, the lesion is not so well defined and it is likely to be more aggressive and it has a wide zone of transition. So first the pattern, then the zone of transition and lesion. And those first two things is what the tumor is actually doing to the bone. And the last or the third thing is what is the bone doing to the tumor? How is the bone responding to the tumor? And that is the reaction formed by the periosteum around, which is the lining of the bone. So there are a few categories. From the left, which is more benign nature, where there is a solid periosteum reaction, no destruction of the cortex, gives us a clue that this is a benign lesion. However, as you move towards the right, you see the second picture shows what is classically known as an onion peel appearance, where there are several layers of periosteal reaction because the periosteum is reacting very aggressively to the aggressive lesion. And this is the classical appearance of onion peel appearance, which is seen in Ewing's sarcoma. The third picture shows a sunburst appearance of the periosteum, where you see sun rays emanating through the periosteum. And this is a classical appearance of an osteosarcoma. Also, the other thing, radiological picture that you see in osteosarcoma is a elevation of the periosteum. I do apologize, this is not the best picture. Hopefully we'll see one more picture somewhere with a what is known as a Codman's triangle. So that Codman's triangle is formed by the tumor elevating the periosteum and the periosteum reacting in a sunburst appearance. But where the periosteum is elevated from the normal cortex, that's where a Codman's triangle is formed. And that is also, that plus the sunburst appearance is one of the classical radiological findings of osteosarcoma. And as we discussed, the pictures on the left are benign. However, the three pictures on the right are aggressive lesions. So to summarize, we see the pattern of destruction. We see the zone of transition or the margins of the lesion, and we see what the periosteal reaction is like. So we will go through some cases and we'll try and see whether we can identify these three things. So these are pictures of an ankle. There is clearly a lytic lesion in the zone, in the area of the metaphysis. It does not cross the growth plate. It is lytic and it is geographic, because you can clearly see the demarcation or the zone of transition, which is very narrow between that lesion and normal bone in the diaphysis. This is a classical appearance and classical location of a aneurysmal bone cyst. Now, you can call it a simple bone cyst, but because the nature, the size of this lesion, and also that it is ballooning and thinning out the cortex particularly on this side, if you see on the fibular side, and it has got these striations, this is a aneurysmal bone cyst, and you can see the ballooning on the right picture much clearer. So pattern of destruction is geographic, narrow zone of transition. And if you see the periosteal reaction, there is minimal to none periosteal reaction on these x-rays, which also implies that it's like the bone, the periosteum is not unhappy. It is not aggressively reacting. So likely to be a benign lesion. Now, this is a much better picture for what we were discussing previously. As you can see, again, this is the metaphysis of the lower end of the femur. And this is quite an aggressive lesion. As you can see, it is going far beyond the normal boundaries of the bone into the soft tissues. And you can see the classical sun ray appearance of sun ray spicules. And if you focus on the lateral view on the right side, you can actually see the periosteal reaction and the elevation here and around this area. And this is the classical appearance of what is called Codman's triangle and sun ray spicule appearance. And when you have both these things, the diagnosis is likely to be a osteosarcoma. If you see, the zone of transition is quite wide. We cannot actually see where are the boundaries of this cancer because it blends into the shaft. And so it's a very wide zone of transition with these classical findings. Now, this is an X-ray. It's a close-up view just to highlight the periosteal reaction. Now, this is a upper end, proximal end of a tibia bone. This is the area of the metaphysis and diaphysis junction. So this upper part of the X-ray is the metaphysis, and this is the diaphysis. So the lesion is in the diaphysis of the tibia. You cannot actually see the lesion because it's all blended with the cortex and it's throughout the diaphysis. But what if you look very carefully with the magnifying lens, you have what is known as a classical onion peel appearance. So there are several layers of periosteal reactions. And this is the classical appearance and location of a very aggressive tumor called Ewing sarcoma, as we discussed. This is again a picture of the upper end of the tibia. However, this shows a chondrosarcoma. This picture on the right side is an isotope bone scan, which shows a hotspot. And this is also a very aggressive lesion, highly malignant. So we've seen some X-rays trying to understand how we can get clues, whether these are primary cancers or secondary cancers and whether they are benign or aggressive. So just a repetition of what are the common types of primary bone cancers. We saw a picture of chondrosarcoma, which arises from the cartilage cells. Common age is between 30 to 60 years, and the most common locations are around the knee. However, it can be central in the pelvis and ribs as well. Osteosarcoma is one of the most common forms of primary bone cancers, very common in children and young adults. And also there is a secondary peak, which is due to probably radiation or patients who have Paget's disease. We saw the appearances of sun ray spicule and Codman's triangle in osteosarcoma. Ewing sarcoma is most common, second most common cancer, however, more common in young adults and teenagers. And it's a very aggressive with high mortality. It is common in the pelvis, the chest, and the leg bones. These are some less common primary bone cancers. We don't need to discuss them in much depth, but just to remember some names, spindle cell of the bone is a soft tissue tumor, and the types of spindle cell bone tumors are fibrosarcomas or leiomyosarcomas. Admantioma commonly happens in the fibula in young adults. Angiosarcoma of the bone is a very aggressive but very rare, luckily, fortunately, a very rare cancer. And there is a giant cell tumor as well, which is more a benign tumor. Giant cell tumor is quite a common lesion, especially in upper limbs, and the name mistakenly can be sounding aggressive, but it's a very benign tumor and can be very safely excised. Right, so coming to the clinical presentation, as we saw, we could be at any platform. You could be a physiotherapist or a radiographer, a doctor sitting in a GP surgery, or urgent care center, but we need to be able to clinically examine the patient to suspect a tumor. So the presentation varies depending on the size and location of the tumor. Symptoms appear like, and they can be confusing. They can be like spots.
Sorry, Akil, to interrupt you. We just lost your presentation. It's not shared anymore.
Oh, I'm so sorry.
It's okay. It's just since you started talking about the clinical assessment.
I do apologize. I think something I pressed the wrong button.
Yeah, so no worries.
So shall I start from clinical presentation again?
Yes, that's just that part. Until then, everything was fine. Yeah.
All right. Okay. Sorry, apologies for that. So patients can be presenting with various symptoms, which you need to have a high index of suspicion, depending on the size and location of the tumor. Symptoms can be confusing, and they can present like sports injuries or tendinitis, especially with younger adolescent adults. And in adult group of patients, they could be even presenting like symptoms of arthritis, because sometimes these symptoms can also present with no pain involved whatsoever. As primary bone cancers are very rare, some GPs will have never had come across a case in their early career. And often that's the reason why there is misdiagnosis and delayed presentation. Bone pain could be constant presentation or an intermittent presentation. And in some cancers, the painkillers may not be helping. And classically, some of the cancers, the pain is worse at night. The lesion itself, if it's associated with swelling, it could be tender to touch. But then again, there are some cancers which are absolutely pain-free. A lump or swelling may be seen or felt. However, when there are deeper cancers, like in pelvis, there is no lump available to examine. They can sometimes present as inflammation, redness, and pain over the bone. And one of the classical tumors in children, which we discussed, the Ewing sarcoma, often can be confused as an inflammation or an infection. Patients can present with some unexplained limp. Their gait may be altered, the joints may be stiff if the lesion is close to the joint, and movements may be reduced. So these are clues that we need to be having. As long as you have a high index of suspicion and you're looking at your x-rays carefully, you can put two things together and make an early diagnosis. There may be some systemic symptoms that the patient may have been experiencing, like tiredness, night sweats, weight loss particularly. And sometimes, or quite often actually, if the diagnosis has been missed or there's been delayed presentations, the first presentation the patient can come to you could be with a pathological fracture. So any fracture in a otherwise normal person, you have to have a high index suspicion, especially if the patient has a primary tumor elsewhere. Often you see lumps and bumps in the body, and you may think, what are the clues that this could be something more sinister or serious? And some of the key things that you need to see to suggest that this could be a malignancy is if the lump is extensive or significantly big in size, more than 5 centimeters. If the lump has been progressively increasing in size. If you do a CT, an MRI scan or an ultrasound scan, and you find that the lump is deeper to the fascia and in deeper tissues, you need to have a high index of suspicion that this could be a malignancy. And if it's associated with pain. So in terms of diagnosis and the tools available to us, once you've had your clinical examination with a high index of suspicion, you reviewed the x-rays, and you are thinking of a cancer, the first thing in mind should be, how am I going to quickly refer this patient to a tertiary bone cancer center near you, or an expert who deals with this problem day in and day out? This is not a condition that one should deal alone or cause any delays in escalating of the further referrals. So we've seen the X-ray. So if you are in a district general hospital and you have facilities, you should try and organize urgent further radiological imaging like CT scan with or without contrast, MRI scan with or without contrast. PET scan is optional and usually done in tertiary centers. Isotope bone scans can be done, but they're only relevant in certain tumors and they're not essential. Routine blood tests should be done as well. Bone biopsy is a diagnostic tool which confirms the histology of the tumor. But bone biopsy, the main thing to understand is should be ideally done in a tertiary referral center where there are facilities to do further management and treatment. And there are certain specific principles involved around bone biopsy, which is another topic of discussion for higher graduates. So what we were discussing is that there is a multidisciplinary approach involved where we have passed the stage of referral, and then we have involvement of all specialists who deal with this on a day in and day out basis. This MDT team involves specialist sarcoma surgeons, specialist radiologists, pathologists, oncologists, and there are also specialist nurse and key workers. There is also a team of palliative care specialists and MDT coordinators with secretarial support, and this forms a sarcoma MDT team. So we've understood the framework, and we reached the stage where we are in a specialist center and we have to then do a biopsy. What does the biopsy give us? The biopsy basically gives us the confirmation of the diagnosis and helps us grade the tumor. So when we say grading of a primary bone cancer, it means how do the malignant cells look under a microscope? And it gives us a guide as to how the cancer may behave, how aggressive or benign it will be clinically. So when we say it's a low-grade cancers, those are cancers which are benign and less likely to spread, and high-grade cancers are more quickly and more likely to be spread. So that is grading. The next keyword is staging. Staging is a clinical and radiological staging, which is achieved after CT scans and MRI scans have been done. And basically, they tell us whether this is, again, a stage, advanced stage or an early stage of the cancer. So this is one of the commonly used staging for bone tumors, which is the Anakin staging. You can see there are three major categories: stage 1, stage 2, and 3. So stage 1 are low grade, low stage. Stage 3 is when this cancer has metastasized. This is another staging system, which is the T and M staging, which is also used for visceral cancers and can be used for bone cancers as well. Again, I'm not going to go into too much depth of this. I'm sure the clinicians would have come across this staging in various other cancer specialties. There are some nice recommendations regarding management of bone tumors. And the topmost, as we discussed, is a multidisciplinary approach. And the tumor should be referred directly to a bone tumor treatment center closest to you. Cancer networks are available in the NHS who arrange diagnostic services. There are special commissioners, and they should fund a formal system for second opinions and difficult cases to places where facilities are available for doing molecular pathology and cytogenic facilities. Soft tissue sarcoma MDTs should meet some minimum criteria and manage the care of at least 100 new patients with soft tissue sarcoma per year. NICE has also recommended that definitive surgical resections of malignant tumors should be performed by a skilled surgeon who is a member of Sarcoma MDT. NICE has also given recommendations around modalities like chemotherapy and radiotherapy, and facilities should be available. Patients should be informed about relevant clinical trials regarding around the specific cancer that has been diagnosed. All sarcoma MDTs should participate in national audit data collection and training. There should be timely access to appropriate support and rehabilitation services. There is a national specialist commissioning advisory group as well, and national implementation group to supervise these NICE recommendations. So these are the key points that we have discussed. Just to summarize again, bone cancer, they can be rare tumors, but early suspicion and accurate clinical diagnosis is essential. There's approximately 400 patients diagnosed with bone sarcomas. 2,000 with soft tissue sarcomas are diagnosed per year in England and Wales. Diagnosis, as we said, is often not suspected before biopsy or excision. Diagnostic pathways is better described for bone tumors than for soft tissue sarcomas, and hence the soft tissue sarcomas often can slip under the net. There are a significant number of patients, especially soft tissue sarcomas, which are probably not managed by an MDT. And just to recap, peak incidence of bone cancers often can happen in children and young adolescents. Now, let's see a few management options. First of all is surgical interventions. These are, again, as we said, done after biopsy and diagnosis, and grading and staging has been done. And these should be done in the tertiary bone center under the auspices of a multidisciplinary approach. In most cases, at one of the 5 bone cancer centers in the UK, decisions for surgery are made by the MDT by an experienced surgeon, and the extent of surgery will depend on the location, stage, and grading of the tumor. The aim of any surgical intervention of a primary bone cancer is to completely remove the primary cancer with as little effect to the body as possible, so the tumor can no longer grow or spread. There are certain surgical techniques. I've highlighted them in green. Again, we're not going to go too much in details at this level, but to highlight, there are surgical techniques of resection of the tumor. One can use autograft or allograft to substitute for any bone losses as a result of the surgical excision. We can use radiation to kill any tumor cells. And if there are joint involved, we can use metal prosthesis to replace the joint that has been destroyed as a result of excision, surgical excision. Unfortunately, sometimes these above options are not possible, and there are several compartments of the limb involved, and the only option available is an amputation. There are some palliative cases where none of these surgical options are possible, and there palliative chemotherapy or radiotherapy can be used to prolong the lifespan. So just a few notes on chemotherapy. Chemotherapy can be used as neoadjuvant chemotherapy, which shrinks the tumor before surgery, before we do any surgical procedures as discussed before, to shrink the tumor, which allows easier surgical access procedure and sparing of removal of the unaffected areas. Adjuvant chemotherapy, on the other hand, is done after surgery and kills any micrometastasis or any neighboring remaining cancer cells, and that reduces the risk of it recurring. It improves the cure rate for primary bone cancers and is delivered in cycles. Stem cell transplants or bone marrow transplants can replace some damaged blood cells, especially useful in hematopoietic malignancies, which we haven't discussed too much. Some things like lymphomas or myelomas. And again, we're not going to go too much in details with that. Radiotherapy can be used as a localized treatment using high energy X-rays to destroy cancer cells. Again, this can be used before surgery to shrink the tumor or after surgery to remove any remaining cells so that the recurrence is low. Standalone treatment with radiotherapy is only used for the palliative treatment of inoperable tumors to control pain. Proton beam therapy is also one of the treatment options available. So once we've completed the surgical treatment with or without adjuvant radiochemotherapy, then comes the role of rehabilitation services, which also forms important part of the multidisciplinary approach. This involves physiotherapists, occupational therapists, dietitians. They could be psychotherapists involved in psychological support, as this is quite a life-changing diagnosis and treatment for a patient. There are local support groups available for cancer patients. Physiotherapists and orthotists can provide splints and footwear, special footwears, or artificial limbs can be provided where amputation has been considered. These are some of the key references. If you wish to study more into this and go into the depths of this topic, you can make a note of them and do a bit of reading. Nice guidelines are always very helpful. So that concludes my presentation in terms of what I had to say. I kept it brief and hopefully you enjoy that. Over to you, Faraz. We can start with MCQs if you want to make it.
Sure. Thank you very much, Akil. Yes, that was brief, but also quite comprehensive. It's a massive topic, isn't it?
It is, yes.
And cover orthopedic oncology in a short session is impossible, but you went over all the main diagnostic criteria and management principles, how to differentiate between benign and malignant tumors and all of that, and the importance of MDT. We don't expect even senior consultants, they might not be sure about the diagnosis.
Yes.
So guys, don't be worried if you're not sure, is this fibrous dysplasia or is it a bone cyst, or is that, if you're worried in your clinical practice, always refer, always investigate and always refer, If you're not sure what to investigate, exactly which investigation to do, ask for advice. And there are specialists, as Akil said, a whole MDT team who was specialized in management. And these people, they can do scans and still not sure about the diagnosis. And they do biopsy, and sometimes even after biopsies, they're not sure. So this can be very difficult sometimes to diagnose. But I think our main message to you guys is that if you are concerned, always refer, always refer. And this patient should be seen within 2 weeks. In the NHS, there is a 2 weeks waiting pathway. Brilliant. So let's do the MCQs. So 3 MCQs, guys, I will share. So this is the first one. First question, Akil, if you want to.
So yes, so I kept that X-ray of the knee, as you can see, which shows clearly a lesion. So good. On the principles, on the principles we discussed, think and try to figure it out. What is the location of the lesion? Whereabouts is in the bone? Is it looking? What is it doing to the bone? Is it going beyond the bone? Is it inside the bone? Can you see the margins of this lesion? And what is how is the bone reacting to this lesion? So that gives you an idea whether this could be a benign, less aggressive lesion or a more aggressive malignant lesion. And as you can see in the 5 options, there are a few benign lesions and there are a few more malignant looking lesions. So pick up, certainly I am sure nobody has picked up a normal X-ray so far.
Okay, guys, the answers are all anonymous. So encourage everyone to try. That's how you learn and that's how it sticks to your memory. If you get it right or wrong, you will not get it wrong again in the future if you try to answer. Okay, all anonymous, please all try. And while you all guys do, so if anyone is, you know, this polls box, guys, if it is in your way, you could just drag it to the side to see the X-ray. I just shared the feedback link. Everyone who fills the feedback link will get automatically a certificate. So please let us know how this went. And reviews are important, feedback is important, and what else we can do for you guys in the future. What other sessions you might want or looking forward to, or something that's missing from your normal education, something you want more in-depth information about, or so just let us know, please. We'll appreciate it. Good. So I think we will end this poll now. Can you see we'll see the results.
Yeah. So I'm very pleased to say that most 56% of the people have selected osteosarcoma, which indeed is the correct answer. So you can congratulate yourself for that. So we all can see that this is a lower part of the femur. It's roughly in the metaphysis. It is going beyond the boundaries of the cortex. So it's more than likely to be a malignant lesion. So it's not a normal X-ray. It's not an osteoid osteoma because that has got a very, very small nidus and some solid periosteal reaction. It is not a, so that leaves us with, it is not a benign exostosis, even though it is, for people who have chosen benign exostosis, it is a common location, you're quite right. However, if you see the boundaries of the lesion, they are not very well defined. They are, you know, irregular, and there is some periosteal reaction, which is not very clearly visible here, but it is not that well defined, like a pedunculated benign exostosis. If you look at a picture of exostosis, it's much more well defined and rounded. So it is certainly malignant. Okay, so it is not an Ewing sarcoma, because an Ewing sarcoma, as we discussed, usually is in young adults, and we should have seen a growth plate somewhere on this X-ray to suggest that this was a child. So that's what you need to look at. And also an Ewing sarcoma is more commonly in the shaft of the long bone, and it is associated with onion peel appearance. So this is not in the shaft of the bone. So that leaves us with the option of osteosarcoma, which is the correct answer.
Good one. Should we do the second one now?
Yes, sure.
Do you have a slide, Akil, of the second one?
So this is a 75-year-old gentleman who has presented with shoulder pain going on for 9 months. This X-ray shows a lesion. As you can see, it's a lytic lesion in the upper end of the humerus. Have a look at it. Think about, what does it look like? Does it look benign, or does it look malignant? Does it look very aggressive? Are you going to be worried about it? What are you going to do? Say you're sitting in an urgent care center, you come across this patient with an X-ray looking like this. What are you going to do? You've got 5 options.
Okay, guys, each one of you, imagine you've got this case tomorrow in your clinical practice.
And it's the first time this patient is presented in the clinical setup. And you are the first person who has encountered and is dealing with this patient. What's the first thing that you would like to do?
just to say, guys, for those who asked, I've just shared the link to the Orthopedic Principles course, which covers the whole syllabus of orthopedics for those who are interested in this specialty. Also, guys, if anyone has any question about any of the cases we're discussing today, any of the topics, anything is not clear, please don't hesitate to ask us. Yeah, we can write in the chat box or you can speak directly. Please don't leave tonight if you have any doubts or anything not clear. There is no silly questions. It's a difficult topic, and it's normal to find a few things confusing. I know there was one of the feedback written is someone wanted to know more about the staging, Akil.
Yes, okay. I can go back to that slide.
Can maybe recap on the staging for you a little bit, just to,
sure,
at the end. Good, so shall we end this one?
Yeah. So again, I'm pleased to say that 75% have got it right. The correct answer is to do further imaging like urgent CT scan and MRI scan, and have a multidisciplinary team discussion or urgent referral to the oncology team. That is the correct answer. Now, I appreciate 2 of you have picked up the option of sling and analgesia. And I deliberately put that option because, yes, you're quite right. Sling and analgesia will also be probably necessary. But I wanted to highlight and remind you that the first thing that should come to your mind when you see such an aggressive lesion is MDT. Okay, sling and analgesia can take place at their sweet time. You know, you may not have any analgesia available. Pharmacy might be closed. Okay, you may not have anywhere to give a sling. That is not crucial. The most crucial thing is an MDT approach. You cannot let that patient disappear or go away without you having done the next appropriate escalation of management. So hence, CT and MRI and MDT is the correct answer. Okay, good. Should we go to the next one?
Yeah.
Okay, so this is a 15-year-old adolescent. As you can see, he's still got a growth plate on the X-ray of the wrist, and he's got this lesion at the lower end of his radius. Please review it and pick up your best option.
Okay, guys, as Nikki said, please, if you have any other topics you want us to discuss again in the future, please let us know. Communicate with us, orthopaedacademy.co.uk. You can email us. You can find us on social media. Just send us a message and we will do our best to fulfill your requests. If any topics or anything part of the orthopedic curriculum that you want covered, let us know.
I think we should end this poll. 14.
Yeah.
Again, I'm very impressed. 93% have picked up the correct diagnosis of aneurysmal bone cyst, and it just proves that they've understood that even though this lesion looks quite large and aggressive, it is actually a benign, classical appearance of a benign-looking cyst, which is the aneurysmal bone cyst. It's got a balloon appearance, very classical, and there is minimal to no periosteal reaction. And just as a reminder, just to remember this, because of the extent of the lesion and the location, these patients are at risk of developing pathological fractures. Good. So
That's
I
great.
think,
Yeah, well done, guys. You clearly have been listening,
I
and
think you've done very well.
it's very pleasing to see. Yeah, good
And
answer.
I'm quite impressed. Everybody was paying attention. So this is just some case discussion now. I mean, I'm not sure, Firaz, if we can make it interactive, but if somebody wants to participate, but otherwise I can just talk you through.
If you don't mind, yeah.
Yeah, okay. So if you look, the things you've been given an X-ray. This is a real patient who's been complaining of hip pain. And as you can see, the growth plate is still closing. So you could roughly estimate that this will be a late teenager in his 17s or 18s. And you picked up a lesion now. Again, revising what we discussed before. First, we identify which part of the bone it is in. It's in the metaphyseal area. Then we see the pattern of destruction. You can clearly see that it's a geographic lesion, very well defined, and it has a very narrow zone of transition. It suddenly changes from a lytic to normal bone, so it's very narrow zone of transition. And if you look at the periosteal reaction, there is minimal to no periosteal reaction at all. So in all probability, this is likely to be a benign lesion and not an aggressive lesion. And possibly this is more likely to be a simple bone cyst. It is not extending throughout the width of the bone, so the likelihood of pathological fractures is also less. So essentially, this is a benign lesion and can be treated symptomatically. Some of them, if they are slightly smaller than this, can present just like an incidental finding and not even have bone pain. Okay. On the contrary, I wanted to pick up this X-ray, the series of X-rays. And if you see, start from the left, this is an X-ray of the shaft of the femur, mid shaft. And you can see that there is clearly a pathological fracture through what looks like a lytic moth-eaten lesion, where the margins or the zone of transition is not very clear, and it's not a very well-defined lesion. So this is likely to be a very aggressive lesion, which has eroded the cortex and led to a pathological fracture, in contrast with the lesion we saw before. And the X-rays on the right just show how it has been managed with some cement spacer and graft in the middle and an intramedullary nail. I wanted to end up with this particular X-ray. As you can see, this is an X-ray of the shoulder and proximal humerus, which again shows a very diffuse lytic area in the whole of the proximal shaft of the humerus. It has no clear margins and has got a significant periosteal reaction with multi-layered, classically known as onion peel appearance of the lesion. So as a recap, this is diaphysis, this is metaphysis, and the lesion, if we had an X-ray of the whole of the shaft, you could see the lesion extending all throughout the humerus towards the diaphysis as well. And with the classical appearance of onion peel, that is surely a Ewing's sarcoma, which is a very aggressive lesion in young adults. As you can see, there is still the growth plate there. So, it's likely to be a teenager who has got this very aggressive lesion. So I hope that recaps some of our benign and malignant aggressive lesions. Thank you.
Excellent one. Thank you very much, Akil. That was a very good case to finish the day with. Ewing carcinoma, Ewing sarcoma. Thank you very much for this wonderful session.
You're welcome.
I really enjoyed it.
Yeah, I hope everybody enjoyed that.
Definitely, I did, and I think we've had excellent feedback. If you don't mind, just quickly go through that staging.
Oh, yeah.
Just a quick one recap. I think we don't have to worry too much about the staging at this. I think Akil has just put it there. just to make sure he's covered the
Yeah,
whole topic for you, so you know
yeah,
about it.
yeah. The reason I didn't go into too much details is because so basically, just to recap, grading is low grade or high grade, and that is based on microscopic assessment of tumor cells. That is grading. But staging is how far the tumor has spread, whether it's localized in a particular compartment, or which is bone, or it has gone into the muscles and surrounding fascia, or it has crossed compartments and possibly even gone through blood vessels and gone elsewhere in the body, right? So that is what staging is. And it is very important because the treatment differs. In the early parts of this Anakin staging, which is stage 1A, the tumor is localized to the bone. In stage 1B, the tumor has gone through the bone wall. Like, for example, we saw that proximal humerus lesion with that 75-year-old, question number 2, which had eroded the cortex and it had gone through the bone wall. It has eroded the cortex. So that will be a stage 1B. Yeah. Whereas a tumor which is restricted inside the bone, has not eroded the cortex, is stage 1A, right? So these are low grade staging, early stage of cancer. In stage 2, it has gone furthermore. It has stage 2A, the tumor is localized to the bone, and stage 2B, it has gone through the bone wall. But when we have looked at it under the microscope, and we've seen the tumor cells, their mitotic activity, we found that they were high-grade tumors. So a combination of a high-grade tumor found after biopsy with clinical and radiological appearances which are similar to stage 1 will put that into stage 2. Yeah, I hope that is clear.
Yeah.
And then stage 3 is when the tumor is irrespective of what we found as regards the tumor cells are and what the grading is, irrespective of that, but it has spread beyond the boundaries of the compartment of the bone and it has gone to other parts of the body or metastasized. So that's stage 3.
Great. So to get to stage a tumor, you'll have to have both histological
Correct.
Diagnosis, as well as diagnostic modalities to tell you how spread the tumor is. Yeah.
Correct.
And as you know, guys, if you go up the stages, it's obviously this more advanced and more difficult to treat. Great. Well, thank you very much, Akil. We had a wonderful feedback, which I will share with you later.
You're welcome, and thanks for
thanks to everyone who
thanks for inviting me as well.
Thank you, Akil. It was a wonderful session. I enjoyed it. I think it was a very good review of the topic. And I'm very happy that our delegates had enjoyed the session, and we tried to keep it as interactive as possible for you guys. And I hope that worked well, but we welcome feedback. Any comments, Nikki?
No, I thought it was a good overview of the basics of orthopedic oncology. You've already answered the one about pediatric fractures, and I just wasn't sure about I can't see his question now. Georgios was asking about polytrauma. So we covered code red, didn't we, in the principles course, but I wasn't sure whether it was more to do with ATLS or damage control versus early intervention. I wasn't sure what you wanted, Georgios, but if you let us know, I'm sure we can look into it.
Yeah, we definitely can look into it. Yeah. Just email us, George. Just email us at contact@orthopedicacademy.co.uk what exactly you want.
And Shalampos has asked for more often. We're happy to do that, aren't we?
Yeah, we try to do as much as possible. Obviously, our faculty, they're busy with their daily jobs. We will be, our next planned session will be on rheumatology related to orthopedics. I'm not sure exactly when it's going to be, but hopefully in January. So we will all see, guys. Just stay in touch with us and follow us on social media. and various platforms and Medal and all of these, and you will know about it. Good. So on behalf of myself, Orthopedic Academy, I would like to thank Mr. Kapoor for this wonderful session. Thank you very much, Nikki, for being with us this evening, keeping an eye on us. And thanks for everyone who attended. All the best for your career, and we hope to see you again in future sessions. Good night.
Thank you very much, Firas, for inviting me once again. Good night.
Thanks, everyone.
Thanks, Nikki. Bye.
Bye.